So my name's Dr. Williams. I'm from Associated Urologist of Orange County, which is right down the street. I just joined Drs. Trzaki and Greenberger and Pierce, which some of you are obviously patients of theirs. And basically, just a brief introduction. I'm originally a California native. I come from Huntington Beach, California, where I did a majority of my education. I just finished my training at Harvard, where I trained with the leading experts in the field at the Dana-Farber Cancer Institute, one of which actually I know Provenge, some of you may hear about the immunotherapy. I actually worked with the principal investigator, Dr. Kantoff, on that trial. I'm an expert reviewer for all the major journals, Journal of Urology, Urology, Journal of Endourology, just to name a few, as well as Men's Health. Personally myself, I performed over 100 robotic prostatectomies as well as over 100 open prostatectomies, which I think is very rare in today's training because now everything's done robotically, but doing both of these you have to walk before you run. So it's definitely aided me in my understanding and appreciation of the consequences of the surgeries as well. I'm equally experienced in diagnosing and managing urinary incontinence and erectile dysfunction, and in addition prostatic surgery. And now I'm a physician with Associated Urologist Orange County and on staff at St. Joseph's Hospital. Here's the contact information, which some of you have already. I apologize, I'm in the way. So, what is urinary incontinence? I think we all know the definition of that, or maybe experiencing it. But it's the involuntary loss of urine consequent to bladder and/or sphincter dysfunction. Basically, it's my plumbing has a faulty washer, if you will, is the simplest term. There's three different types of incontinence. There's stress incontinence, which is with cough, laugh, or sneeze, or any increase in intra-abdominal pressure, you leak urine. There's urge incontinence, which is associated with urgency, needing to go, and you can't hold it. And finally, I think one of the more common is a mixed incontinence, which is a combination of the two. So how does the process work? It's obviously not as straightforward as everyone would like to think. Thank God, because I went through a lot of schooling to understand this. Bladder collects the urine. It's both a storing as well as a voiding device, if you will. The sphincter is it's a circular muscle, but not entirely circular. It wraps around the urethra, and posteriorly, or at the bottom of it, is not exactly unified. And it relies kind of like a sling effect, if you will, to control the urine. So there's different etiologies to incontinence. I think one of the things here in this group possibly is prostate surgery, radical prostatectomy, or if you had any outlet form of a procedure for BPH. There's other pelvic surgery, spinal disease, and neurologic diseases. So I think, as you all have attended these meetings, you're not the only ones that leak urine. There's, believe it or not, almost 60 million men worldwide who suffer from involuntary loss of urine. And the rate of incontinence ranges between 1 and 31% after prostate surgery. So obviously the treatment of incontinence, it's not socially, appropriate, so to speak. And the return to usual lifestyle, regain dignity, intimacy, save money on protective garments, which I think is significantly underestimated depending upon the severity of incontinence, and to improve the overall quality of life. So this is just basically illustrating the social reasons for proceeding with incontinence. So, do I have to live with incontinence? And I think we all know the answer to that. No. And can I live life dry? And I don't think everyone appreciates this, but the answer is yes. So, with an office visit, if you were to come into my office, what we would do is do obviously a history and physical exam. A neurologic exam, it's not the same as what you would think with electrodes and things of this nature, but there's different reflexes that we would assess in the office to ensure there's not a neurologic component. Always ruling out an infection is the first and foremost. Obtaining what's called a post-void residual, which is basically scanning the urine after one empties to make sure you don't have any overflow. And depending upon the constellation of these findings is whether or not to proceed with a urodynamic test and a cystoscopy, which is a visual look in the bladder. So management options, pads and diapers are usually the first and foremost, particularly even after a robotic procedure. Today I removed a catheter of a patient. He's completely dry, but I know in my mind he's going to dribble some urine here or there as he's going to recover from his surgery, which is only 2 weeks out. There's medications that we can offer. We're very lucky to have Jenny here today, who is one of our leaders in prescribing medications to help relieve incontinence, as well as devices, of which Pete Shorts is over there, and I've used their devices for years. So what you men know about pads, I think basically there's different types of absorbent pads. I like the male guards specifically. I don't hold any stock in them, but those seem to work out well. It really cusps and prevents the urine from leaking out on the sides. There's, in addition, panty liners and things of this nature. Medication, unfortunately there's no FDA-approved medication specifically for stress incontinence in men. There's been trials suggesting antidepressants because there's receptors located within the sphincter fibers themselves to hopefully stimulate and prevent incontinence, but none of these have been proved to significantly decrease incontinence in these men. I think maybe some of you may know Cunningham clamps or clamps to wrap around the penis itself. Basically, it's just a simple device that can hold the urine, but I think one of the things is having to put something on your penis and then take off to urinate. Some men obviously respond very well to that. It obviates the need of any formal surgery, but I think obviously there's other things that have advanced, and I'm going to talk about some of the other devices that we have. There's condom catheters, which I think are an underutilized option, to be honest, in patients who have either increased morbidities or advanced age, or basically don't want to have any procedure possible, or to undergo a procedure, and those are actually pretty useful. Treatment options, behavioral modification, biofeedback, injectables, and surgery are options. Behavioral modifications, I think at the stage if a patient has after surgery, these are some of the things we suggest, but it's kind of a combination of doing something else more proactive other than limiting your fluid intake. Pelvic floor rehabilitation is actually something we're utilizing here, and I'm helping as one of the primary investigators to do pelvic floor rehabilitation therapy before the patients undergo surgery with biofeedback and pelvic floor rehabilitation to stimulate the floor to prepare for patients undergoing surgery. And here we do robotic prostatectomy. We're going to do not a randomized controlled trial, but a trial nonetheless to assess whether or not this does help. There's literature that does tend to support this, but we have a fabulous pelvic floor rehabilitation program here, which I'm helping start this trial. Bulking agents, I'm not a huge fan of the bulking agents personally. I haven't noticed a great success. Patients that want the least invasive procedure, but to undergo a procedure nonetheless and give this a try, I'm more than willing to at least say the objective data, which is about 17% after surgery. So with those numbers, most patients don't want to go down this route, but I'll talk about other stuff that does tend to work better. There's different slings that are available. AMS has provided a beautiful array of slings. The first one was an in-band sling. I was taught both with the in-bands, but more so with the advanced sling, and I'll talk about the variances of that. And I have a significant experience personally with the artificial urinary sphincter, the AUS. So the different severities kind of dictate which patients would be amenable to which treatments. Patients that leak 1 to 3 pads a day, I think the sling is appropriate for those patients. I tend to go the two pads, depends what you're defining pads, soaked pads, fully soaked pads. I would push it 2 pads. The sling, and I think the advanced sling would be a preferred candidate. All the other ones, I think the sphincter does a fantastic job. And I think the good thing about the slings, if you do a sling first and it doesn't work quite as well, you can always do a sphincter. It doesn't negate you from undergoing an additional procedure, which I think is beautiful, and not a lot of synthetic materials or prosthetics really offer that advantage that AMS has provided us. The in-band sling, I think, is kind of going to the wayside, if you will. Pete, am I right, you think?
Yeah, it's still being used somewhat, but it's moved down to advanced because of the benefits of the advanced.
Correct. So the in-band sling has bone anchors that anchor into the bone itself. Obviously, the risk of that are bony infections, things of that nature. It provides a nice hammock, and you know, because it was one of the first slings to be provided for men with stress incontinence, the satisfaction rate is actually quite high. Go. The advanced sling is kind of the next generation, if you will, and something that I was trained a lot more on, just because the nature is the newest and the greatest procedure to follow. The good thing about this is the continence is immediately restored. The is urethral suppositories, and basically it's a capsule you insert into the penis, and it can cause penile pain, but also oddly enough as well as it can cause a decrease in blood pressure. So the time that we usually do this is in the office to see, you know, how the patient responds, and hopefully, you know, they don't drop their blood pressure too low. Vacuum erection devices are something that I kind of put in between the suppositories and before discussing injection therapy, because I think the injection therapy tends to be the more invasive of procedures, not to belittle the urethral suppositories. And then finally, penile implants. So oral therapies, it works in response to sexual stimulation, and the different pills have different varying durations of activities. Viagra and Levitra tend to be on a similar half-life level, whereas Cialis, now they came up with a new formulation where you could take an everyday Cialis pill, the 5 milligram, but the traditional one has the longest duration or half-life, if you will, up to 36 hours. And that's not the erection, it's just in your bloodstream, so that would be a problem. So vacuum erection devices, these aren't, you know, it just seems a little cumbersome. Patients don't tend to like it as much just because of having to place a vacuum there, the constriction device. It's not natural. I think that's the bottom line. But I think it's an excellent you know, alternative to any other form of treatments, medications, things of this nature, if you're the correct patient and have other issues at hand. This is the suppository device. This is doesn't sell this all that well, but basically you insert the pill into the urethra, it dissolves in the urethra, and hopefully there's a response to for an erection itself. Problem with this, and obviously depicted by this picture, is the penile pain that can be associated with this. Also, too, inserting something into your penis directly in the urethra isn't the most appealing as well. And it needs to be done the first time in the office. So if any of you decide to try this, make sure your urologist, after they prescribe it to you, you don't go home and do this. You have to come back to the office because, like I said before, that drop in blood pressure, that's imperative. And sometimes, I don't know if all urologists are doing this, or physicians that are prescribing it. But make sure you don't do it on your own.
At the round thing?
That's the inserter. So it inserts the capsule through there. So it's kind of a little bit of a pressure reservoir.
Doesn't look like fun.
No. Yes. No. Well, neither is this. So injection therapy is the other therapy that we're able to provide patients. There's different combinations, formulations, bi-mix, tri-mix, which use different agents, varying agents to basically stimulate that vasculature to dilate, allow the blood